Move on to the next presentation. It's by Air Marshal Dr. Pawan Kapoor. And for this session, I'll request our Medical Superintendent, Dr. B.K. Ojha, to please chair the session. Dr. Ojha is a KGMC alumni, did his MBBS between 1986 and 92, MS surgery completed in 1996, then MCH neurosurgery from All India Institute, New Delhi, and has been associated as a assistant professor, started his journey as assistant professor in 2000 and is currently the heading the department since 2010. So it's 14 years now. So, because the time is short, I'll not go into further introduction details. So, over to you, Dr. Ojha, and please introduce the speaker. Dr. Pawan will join us online. Do we have the recording? Recording, yeah. So, okay. Yes, presenting on. He's live on. Live.
Very good evening, everyone. And Air Marshal Pawan Kapoor, sir, we welcome you. So, Dr. Pawan Kapoor is alumnus of AFMC. He did his master's degree in hospital administration from AIIMS, New Delhi. After that, he served armed forces for about 38 years in different capacities and superannuated in 2017 as Air Marshal. He has published more than 40 papers and has been awarded with Visist Seva Medal as well as Ati Visist Seva Medal, as you can see. And currently, he is Honorary Vice Chancellor of the School of Medicine, Lincoln American University at Guyana. So, without wasting time, I again welcome you, sir. And you can share your slides and start presenting. Thank you. Pawan Kapoor.
Yeah, can you unmute me?
Yes, you are unmuted and we can hear you, sir.
Okay, now I'll just share my slides.
Okay.
Are my slides visible?
Yes, sir.
Okay. Thank you very much for the introduction. And in the beginning, I think I know I'm probably the penultimate speaker for this session. I've been here whole day listening to everybody else, and believe me, it was very, very enlightening and very, very informative and educated. So thank you very much. My thanks to the organizing committee and also to Professor Anita for giving me this opportunity to share my experiences on the subject of readiness of teaching hospitals for NABH accreditation. My thanks are also due to NABH for sharing the information with me and to all of you, the participants who have stayed behind to listen at the fag end of the day. So thank you very much. My slides is not, yeah. My compliments to the internal quality assurance cell who have been here on every year coming out with something or the other which is of relevance and contemporary for discussion. So my compliments to them and to KGMU for organizing this National Symposium for enhancing quality in health sciences institutions. I would like to give certain disclosure. Whatever views I express, they have been collected and collated from various input from agencies like NABH, International Society of Quality Assurance, NMC, and WFME. The color of experience has been incorporated wherever scientifically feasible. There is no conflict of interest, and I can assure you that I have not used AI for making this presentation. At the same point of time, before I begin, I must thank Dr. Simita and Dr. Arvind. Whatever they spoke was music to my ears because I am the one who is one of the founder members and who made the first, second, third, and the fifth edition, who was responsible for making all these editions for NABH. So whatever they spoke was really music to my ears. And I saw the passion, and I think, quality in this country is going nowhere. It's only going to go upwards and upwards. But yes, we need to know a different dimension of quality. What do we mean by quality in healthcare? And these are the initiatives which we take to ensure that healthcare remains current, contemporary, safe, and people-centric, which is based upon evidence-based and current best practices, principles, and knowledge. These initiatives should meet all the domains of quality as laid down by the World Health Organization. But I must tell you, these domains have been already told by both of them, Dr. Sumita and as well as Dr. Arvind. So I will not dwell upon it. Only thing I will just say, these dimensions have been slightly revised. We follow what is called the STEEP phenomena, where S stands for safety, but sustainability has been added recently by WHO to this. So it becomes safety and sustainability. That means your patient, you should do no harm, and whatever quality you're providing, it should be sustainable, both in terms that the future patients also receive better and better care, and we do not harm the environment and the community in which we provide the healthcare services. So that what does S stand for? Timeliness stands for the promptness with which you provide care. The efficiency, the way which you resources, with the available resources to maximize your outputs and your productivity. Effectiveness means that whether whatever you're doing has an impact on the patient, on the population, and on the community. Equity means without any discrimination between people of various status, whether it is economic or gender status. Last, patient experience has been now removed with people-centric care rather than patient-centric care, because this domain of quality should reach out to the community. So I think everybody said this, and these are the dimensions which are required for quality. We know what is accreditation, but briefly I will just introduce. It is an external assessment of quality, which is based upon pre-published standards, which are carried out by professional peers, which is administered by an autonomous body, and which focuses on organization or healthcare organizations development. So before I go on to the readiness, I would like to tell you some stories. This is the first story that I would like to tell you. This story occurred in 1992, when nobody knew about quality, when there was nothing like NABH, and the only thing accreditation we knew about was it was a short note asked to residents of hospital administration in their examination. And sometimes somebody wants to get funny with you, is to ask you the spelling of accreditation. This is a story of that time. Year is 1992. 13-year-old son of a widowed mother who was traveling along with her in a three-wheeler. This three-wheeler collided with another three-wheeler which was carrying gas cylinders. Mother was thrown out of the auto, but the child got trapped because on one side there was a railing in the auto. The auto caught fire, and the child sustained multiple injuries with severe burns. The mother took her child to 4 teaching hospitals. Not even first aid was provided, only were being referred from one place to another place. Finally, child was admitted in the 5th hospital, and what is known, the child had to succumb, and the child succumbed. So I'm sure you all know that this is not quality of healthcare, but I think we can say that the term quality was not so much used in the year 1992. Now we come back to year 2024, and this is the second story. 45-year-old belonging to low socioeconomic status got a stroke in Uttarakhand, taken to government hospital. He was referred through separate hospitals to visit one of the premier institutions in Delhi. When the ambulance reached that premier institution, the emergency medical officer of that institution saw the patient in the ambulance and said the patient is now too late for any active care. The patient only needs OPD care, so please bring the patient on the next day of the OPD. And by the next day, the day came, the patient had already succumbed. So this is the time when NABH was fully operational, their 5th edition was operational, and quality is the buzzword. There are patient safety conferences, quality conferences being done everywhere else. Now, this is the second story. Both stories are that of teaching institutions. Why do these events occur and recur every now and then? Are we casual about the care that we provide? Do we consider human life to be insignificant in a heavily populated country? Or do we follow the doctrine of passing on the buck to someone else? Or else we do not have standardized procedures and training on steps to be taken when confronted with similar situations in our day-to-day activities, and there is lack of awareness among staff on correct procedure to be followed, even if they are documented. People think that non-teaching hospitals are well organized and they go like an organized traffic. It is not so, but it is generally felt like that. And teaching hospitals have these problems. Dr. Simita gave a wonderful talk on the challenges that you face for NABH accreditation. So I will not go into details, but these are the challenges faced by teaching hospitals. They put on multiple hats. They have to do patient care, which has to be amalgamated with teaching and research. So the goals become manifold. Then there is a problem of autonomy and interdependence. The hospitals depend upon the teaching faculty, and the teaching faculty has to depend upon the hospital. Teaching have the goal of ensuring quality teaching. The hospital has the goal of providing quality patient care. So they have got different goals. For each goal, there are different protocols. For each protocol, you have to be dependent upon each other. To bring them together, they've already brought out, it's very difficult in a very highly educated environment to bring people together, because there's always variation in perception and variation in knowledge. Add to that is the large turnover of trainees. You train one batch of trainees, the next batch comes then in the hospital, so you train them again on the standards, on the protocol, so you require continual training. There's the apprentices model of training. This is on the job, so at that time it becomes difficult to maintain the standards. There are multiple accrediting agencies. You see, imagine a teaching hospital has to also undergo inspection by National Medical Commission. If you are applied for NAC, NAC will also come and do your inspection. Then you apply for NABL, so NABL will also come and do their inspection. Then you apply for NABS, so NABH also come and do it. Now what is happening is multiple inspections. Each inspection has a difference in expectation, and it leads to confusion in the mind of people. What are we doing? Whether we are going in the right direction or not, because NABL will come and ask something else. NABH will come and ask something else, and both relate to the lab. So it leads to confusion in the mind of the people. So this is the challenge. Of course, staffing pattern and hierarchy has already been discussed, so I won't go into details. You do require staff, you do require the hospitals to be manned appropriately. There is a problem of patient load. Although, yes, we can say most of the people want to go and visit private hospitals, but we also know in this country, majority cannot afford it. Most of them are still not covered by any insurance plan. And so many will still find their way to the government hospitals. So when you come to government hospitals, there are problem of work overload. We all understand that work overload will continue to remain. So can you give quality and quantity will remain a challenge. Again, if you standardize everything as per the NA-based standards, then the medical college asks, where is the scope for innovation? Where do we try to innovate new practices when we have to follow best practices? So if you standardize everything, then how do we become creative? Again, there's a challenge, cultural change is required in your mindset, in your attitude. There is difficulty in performance-linked appraisals, which is on the job, and difficult to maintain standards of performance as a teacher, performance as a researcher, and performance as a healthcare provider. But what teaching hospitals have that others do not have. So let us see the plus side of the teaching hospitals. The teaching hospitals have a learning environment, which is manned by academic minds, which have research orientation, which are very inquisitive. We like to ask the question why, when, where, and how. So they're actually intuitively involved in an internal audit of the quality of care that they are providing, because they're inquisitive. Both the trainees and staff are inquisitive. They have a flair for challenges. They don't back out from challenges. They like to face the challenges right in the front of it, not behind, getting behind somebody else's screen. And of course, they have inbuilt an intuitive system for corrections of deviations. This is what teaching hospitals have got, which other healthcare organizations do not have. So when you have to prepare yourself for accreditation, this strength has to be kept in mind. And teaching hospitals therefore become easily amenable to following standard, to setting of standards as well. So next question is, are teaching hospitals ready for accreditation? Now, I have certain case studies from teaching hospitals which I've gathered over a period of time. I'll quickly go through them and I'll leave the question in your mind whether are they ready or not. See, this is a 50-year-old lady who underwent a CABG surgery and was admitted in the ICU on the second post-operative. She had a post-EABG psychosis. So nursing in charge rings up the doctor at 6:30 p.m. Doctor advises 10 milligram of compost to be given orally. Lady visits the toilet. The time for turnover of the nursing staff is 7 p.m. So the nurse visits the patient in the toilet and gives the 10 milligram compost IV. Obviously, the lady was found in deep sedation on the floor of the toilet with a lacerated wound forehead. Everyone did what they were supposed to do, except that the doctor said it should be given orally. The sister thought that she's showing so many features of anxiety and restlessness, she gave it intravenously. This is a typical case of a verbal order policy either not being in place or individual not being trained, or it has gone horribly wrong. The second case study is of two ladies, both are 28 years old. Both are named Leelavati. One is for cervical ligation for recurrent and midterm abortion, and another for dilatation and curettage for MTP. Both are sitting in the preoperative area. The one Leelavati who had to undergo abortion went away to the toilet. So when they called out Leelavati's name, who had to go for cervical ligation, she went in, and instead of doing cervical ligation, because they had called for MTP, they did her MTP. So the procedures got reversed because of same names, a classical case of wrong patient identification. This happened very recently, about 4 years back. 35-year-old pilot admitted for fracture avulsion of distal phalanx in left ring finger, taken up for surgery in a tertiary care hospital, teaching hospital. After surgery, the patient wakes up to find that he has more pain in the left middle finger than left ring finger. Now it is revealed by the surgeon that he had accidentally explored the left middle finger initially, and subsequently realizing he did the corrective surgery on the afflicted finger. A classical case of wrong size surgery. It happened because it did not have checklists in place, and if checklists were in place, which in this case were in place, they were not followed and not taken seriously. Another case study, patient 65-year-old underwent TURP. Obviously, he wanted to go repeatedly to the toilet to check out the stream flow of his urine. One such visit, he slipped, fell and sustained fracture neck of fever, a case of a sentinel event. He was not briefed. His relatives were not briefed. There was lack of communication between the care providers that during this period of time, he should, at least for the next 48 hours, he should try not to go to the toilet without support. Next case study, again a 47-year-old lady who had undergone hysterectomy 2 months ago, reported with frequent bouts of fever and pain in right iliac fossa. Ultrasound revealed fluid collection and acquiring a foreign body. The lady was taken up for laparotomy, and a pus-soaked gauze piece adherent to the colon was removed, along with a piece of ascending colon. Again, surgical safety checklist was not followed in terms of counting of the gauze pieces. Okay. The same case comes back 2 weeks later after discharge with the same complaints and similar US findings. Laparotomy revealed another retained gauze piece. A classical case of counting error by the sponge counting nurse. 8 gauze pieces had gone in and 8 had been accounted for. That included the one that was removed. Actually should have accounted for 9, but she counted for 8 again. So again, a case of non-implementation of surgical safety checklist. This is a very, very sad case. A physician writes an order for adding primidone, that is misolin, to the existing medication for a 12-year-old boy with a seizure disorder. Misreading the physician's handwriting, the pharmacist mistakenly dispenses prednisolone. For 4 months, the boy receives prednisolone along with his other seizure medication, causing steroid-induced diabetes. And the worst part was the diabetes goes unrecognized, and this child dies of diabetic ketoacidosis. This is a case of medication error which should never ever have occurred in the first place. I can go on, But now you all, if I had been live with you, I would have asked you this question, could these have been avoided? And like Dr. Simita said in her presentation that 50% of all the errors are avoidable. So all these errors could have been avoided. And if this could have been avoided is how? You can avoid them by standardizing your procedures and processes that are amenable for standardization, by following best practices and by making strategies to put your intent into into providing good care into actionable tasks. And the only way of doing this is by following the national accreditation standards, that is by NABH. You can follow any standards, but since we are talking of India, NABH is the set of standards that you should follow. And I think that is the only way that we should prepare ourselves to ensure that we do not commit these errors over and over again. Why do fires happen, and why don't we learn from those fire outbreaks? Why do we don't respond in a correct manner every time an adverse event takes place? That can only happen if you standardize your procedures. Only by showing intent that we wish to standardize our procedures, we can get ready for accreditation, be willing to overcome the challenges. Otherwise, challenges will remain so. We will continue to maintain status quo, be in a comfort zone. We'll operate from the mindset that nothing will ever change. In fact, maximum changes have occurred in healthcare in my almost 7 decades of lifespan. So what are the strategies? It has been told to you and beautifully presented by Dr. Smita as well as by Dr. Arvind. You require top management commitment involvement. In case of KGMU, it is there. I can see it for the last 3 years. I've been a part of the quality journey, and I know that when they take up anything related to quality, they go into it full-fledged. So your next step is to form multidisciplinary committees after getting the top management into the game. The multidisciplinary committees are many, but some are essential. That is quality and patient safety, your infection control committee, your drugs and pharmaceutical committee, your committee for grievance, and your CPR committee. Otherwise, you've got many other internal audit committee. You have got your biomedical waste management committee, grievance committee. There are several committees. So these committees had to be formed. Then you need to get to know the standards. What I recommend that please have NABH to come out to you, visit you, and conduct a 3-day program of implementation to get ready for the NABH accreditation. That program of implementation will remove a lot of cobwebs from your minds and will ease your process of going into the system. It will require documenting of policies, processes, and parameters for measuring outcomes as per the broad guidelines given by the standards. What is important is do what you document. Then check whether what you have documented is actually in sync with your actual practice and whether it is synced with the best practices available. Then once you document what you do, then you document what you do. That is, you implement the documented practices. You do internal audits, identify your gaps from the standards, take corrective and preventive measure to cover the identified gaps, submit application to NABH, and always keep in mind, it has been brought out by the previous 2 speakers, that accreditation is a means to the end. The end is quality. But it is not an end in itself because quality is a journey. It is not a destination. So during the entire process, you have to delegate. One quality team cannot do everything. You have to delegate and empower people to take actions in their own respective departments. You have to identify the champions in each department who have passion for quality. And you have to have target dates. You cannot leave it open-ended. If you don't have target dates, nothing will happen. So like I give you sample time frames. For mapping of standards and gap analysis, 30 days from July to August. For making policy, procedure, forms, new programs, you take another 60 days. For training all staff, training and retraining, you take another 60 days. You implement them in practice. Conduct your internal audits, close the gaps. So if you can see, if you start in July, by next year, March, you should be ready for your accreditation. During this entire process, create an awareness campaign prioritize what is important. So when you identify the gaps in patient care, the gaps in each chapter, which you have got those 10 chapters, you prioritize the gaps where you score the minimum. And then try to work on it and then do periodic review. Even after you got accreditation, you must do periodic review. During the entire process, you have to kill rumors because there will be people, ये क्या चला दिया, ये कहाँ फंसा दिया. So you have to kill rumors. You have to build confidence amongst people, prepare them for change, give them examples of success stories, get cooperation of all, convert me to we and I to us. Involve everybody, involve each and every process owners, get their suggestions and implement their suggestions if they found to be in sync with these standards. Then do an internal audit yourself, submit application. You can call for pre-assessment also. You can have direct final assessment, close the deficiencies. At least if you have done a pre-assessment and once you've got some deficiencies, I would recommend go for a pre-assessment by NABH. It's a very good consultative process where you come to know where you are in this journey of quality. And then you do close that, then do a final assessment, close the deficiencies, you get your accreditation. But the journey has just begun. Because, it is like you are entering into a system. Entry might be easier, people may be slightly lenient with you, but sustenance and maintenance is tougher because when they come back to you for the next cycle, then they will be more strict. So you have to be covering every area of the standards. Like we said, this time we have got commitment, which is to be done. Commitment and core are to be done at your first assessment. They are about, out of 651, they are about 600 and 31 or something. That's 581 standards. 591 objective elements, which you have to do in your first accreditation. After that, you go for surveillance after 2, there are another 60 at the level of achievement. And there are another 30 to achieve at the level of re-accreditation, that is of excellence. So this is a level-based accreditation system. Once you get it, please celebrate the success. We have so many success stories of teaching medical hospitals. We have got Christian Medical College Hospital, Vellore, Kastpura Medical College and Hospital, Manipal and Mangalore, AIMS Nagpur, AIMS Bhopal, AIMS Delhi, RML Hospital Delhi, Safdarjung Hospital Delhi, and RML IMS Lucknow. So these are the success stories. There may be others also which are there, which I have not put it down. Most of these hospitals, especially AIMS Nagpur, Bhopal, Delhi, and RML Hospital Delhi, I have conducted program of implementation, done gap analysis for them. You can call NABH, they will help you. I am always a part of your internal quality assurance committee. I'm always there to support you. So the next success story should be KGMU. So we need your commitment to make a new beginning. And what I would like to end my talk by saying that never doubt that a small group of thoughtful, committed persons who have passion, they can change the world. Indeed, it is the only thing that ever has. So finally, my take-home messages are: teaching hospitals have several challenges in the form of putting on multiple hats, excessive workload, staff and infrastructure-related issues. They, however, have better knowledge resource and greater learning capability and capacity. They just need to have confidence and prepare for accreditation by creating awareness of the standards, documenting the policies, procedures, and practices, implementing them, doing internal audits to monitor performance, and closing the gaps. There are several case studies that reflect that inappropriate, unsafe care has been provided not due to negligence, but due to lack of systems and processes. Accreditation will help to organize the systems and processes and lead to better care and outcomes. There are success stories of teaching hospitals. Accreditation is, however, not the end. The journey has to continue, but we should be prepared to embark on the journey. And this presentation has been just giving you the baseline to prepare you to embark on the journey. Thank you very much, Chair.
Thank you, sir.
Thank you, sir, for such very energizing lecture and you definitely have been able to successfully awaken sleeping minds, and we will follow the enthusiasm that you have produced in us, and we will work on it. Now, I invite Dr. Apul Goyal to speak a few words.
Thank you.
So, I thank you from the core of my heart. Actually, Dr. Anita just showed me a message. You are apparently in Guyana and you haven't slept the entire night. So, thank you so much. And you attended the entire meeting. Thank you so much, sir. So, so we are at the fag end. It's a Saturday evening now. So I'll request Dr. Shalini to felicitate Dr. Oja. Thank you, Dr. Oja, for staying so late. Thank you so much.